Thank you, Mike. It's a pleasure to speak to all of you on the subject of conjunctival pigmented lesions. When should I be concerned? I have no proprietary interest. There are many different melanocytic tumors or lesions of the conjunctiva, racial melanosis, primary acquired melanosis, and others as listed. We'll start first with racial melanosis. I'm sure all of you see patients with racial melanosis every day in your practice. This tends to occur in non-Caucasians as flat perilimbal pigmentation, bilateral, symmetric, very little risk for melanoma, and there's really no treatment. However, be aware that conjunctival melanoma can occur in non-Caucasians. And if you look closely at racial melanosis, you might notice microfolds in the conjunctiva and a fine spray of pigment onto the cornea. This can extend into the fornix. Tarsal involvement is less common. Caucasians can also display racial melanosis, as shown in this illustration. But if racial melanosis is asymmetric, beware. Advise biopsy to rule out primary acquired melanosis or melanoma, as in this 50-year-old African-American woman who had melanoma arising from primary acquired melanosis. Notice the asymmetry. So warning number one, beware of asymmetric racial melanosis. Now the next topic is primary acquired melanosis. This tends to occur in middle-aged patients of light complexion, unilateral, flat, no cysts, and it carries a very real risk for melanoma. According to the AFIP, the risk is 32%. That was a PATH study. According to our clinical study, the risk is about 9%. However, if pathology shows severe atypia, the risk elevates to 32%. PAM without atypia shows progression to melanoma in no cases. PAM with mild atypia, a 2% risk for progression to melanoma, and those with severe atypia, a 32% risk for progression to melanoma. Progression to melanoma, the one clinical factor that predicts it relative to PAM is the extent of the primary acquired melanosis. Each clock hour imparts a 1.7 times risk for the development of melanoma. So if room 1 has this patient with 1 clock hour and room 2 in your practice has this patient with 2 clock hours of PAM, that patient has a 3 times greater risk than the patient with 1 clock hour. And if in the next room you have a patient with 10 clock hours of PAM, that's a 17 times greater risk for melanoma than the patient with 1 clock hour. So it's relative to the extent of your melanosis. Pathology is really necessary to differentiate the atypia from no atypia. We use clinical features, however, to help us in designing whether or not to biopsy PAM. Large size or multifocality, thickening, vascularity, or a history of skin or conjunctival melanoma will promote us to biopsy a lesion. So, for example, this lesion, our suspicion is very low. This is a 1 clock hour area of PAM. Now, we'd be more suspicious of this lesion. There's a little bit of thickening. Maybe that little area of thickening is early melanoma. And in this case, we'd be very suspicious. That portion on the cornea is likely to be microscopic melanoma in a patient with primary acquired melanosis. And again, forniceal involvement makes us a little bit more suspicious. So warning number 2, primary acquired melanosis that's large, multifocal, thickened, or vascular, worry about melanoma. Management of PAM includes excision, cryotherapy, keratectomy, superficial keratectomy, and topical mitomycin C. In this case, we chose to completely excise the pigment, and on follow-up, the patient looked great. And in this case, with corneal PAM, we chose to excise the pigment with alcohol epitheliectomy, and on follow-up, the patient looked great. Now, secondary acquired melanosis can occur from a number of conditions: trauma, inflammation, exposure, systemic conditions, tumors, and others. I'll just highlight a few. Let's begin with exposure. Like this lady who in her inferior fornix, African American, had a pigmented lesion that proved to be secondary to exposure, conjunctivochalasia. And then tumors, there's a poster at the Academy this year by our team on pigmented squamous cell carcinoma, not melanoma, squamous cell carcinoma. And then degenerations like Cogan's scleral plaque can simulate pigmented conjunctival tumors. Now, our old friend, the conjunctival nevus, perhaps the most common conjunctival tumor, is often pigmented. It is discrete, elevated, and the buzzword is cyst. You look for cysts, and that helps to make the diagnosis. It can be pigmented or non-pigmented and carries a low risk, less than 1% risk, for the development of melanoma. About 16% of conjunctival nevi are not pigmented, like this one. Don't mistake that for focal conjunctivitis. Most conjunctival nevi occur in the bulbar conjunctiva near the limbus. In fact, most of them touch the limbus. The mean distance to the limbus in our series was 0, right at the limbus. And beware the pigmented lesion in the fornix, on the tarsus, or on the cornea. It's not likely a nevus. It's more likely melanosis, primary acquired, or melanoma. Conj nevi often show cysts. I show you 4 examples of cysts within conjunctival nevi. So conjunctival nevi are benign, most often located at the nasal or temporal limbus, rarely found in the fornix, tarsus, or cornea. Evolution to melanoma less than 1%. Warning number 3, conj nevus in the fornix, tarsus, or cornea is likely melanoma or primary acquired melanosis. Now how about a few words about conjunctival melanoma? The rate is increasing. In the 1980s, it was estimated about 50 cases a year in the United States. Now it's estimated about 200 cases a year in the United States. The risk for exoneration and metastasis is real at 15 and 25%, respectively. And a nice report out of New York asked the question, conj melanoma, is it increasing in the United States? And the answer was yes. So be on the lookout. It most often originates from primary acquired melanosis, less often from nevus or de novo. Here's a patient with primary acquired melanosis, but it's not just primary acquired melanosis. There's microscopic melanoma at the limbus. And remember, melanoma does not need to be pigmented. It can be purely amelanotic. Good prognosis melanoma is located at the limbus, on the bulbar conjunctiva, and it's thin, less than 1 millimeter. Bad prognosis melanoma is large, diffuse in the fornix, in the caruncle, or on the tarsus. It's very important to do a good drawing prior to proceeding with any surgical intervention. We've described the intervention using alcohol epitheliectomy, dry surface, put away your BSS, don't squirt BSS because that can shed seeds. Remove the corneal epithelium, no touch tumor excision, tumor-free margins on all sides, including the base, specimens submitted to pathology, cryotherapy to the margins, and we always close our wounds. And for those of you interested, there's more information in our textbook. This is a very difficult and delicate surgery. Warning number 4, when you're operating on a patient with possible melanoma, wide no-touch resection, no BSS, avoid tumor seeding. Before surgical excision, this patient had that tumor listed. After surgical excision, the patient looked good with no tumor recurrence. How about if we have big resections where we have to take off a lot of the bulbar conjunctiva? In the old days, we used to go to the mouth or the opposite eye or create a flap. Now we use to seal amniotic membrane, place the membrane down. We to seal under and we to seal over in a Band-Aid patch. Patients look good on follow-up. Custom designed plaque can be used for patients who have multifocal recurrences. Sometimes we even irradiate the entire anterior segment with a conformer plaque. Sentinel lymph node biopsy is still debatable. We offer it to all patients using technetium. We outline where the first node is and have our plastic surgeon go in and remove that first node. Sentinel lymph node biopsy is important. If it is negative, we celebrate. If it is positive, then the patient's life prognosis is better than if we have waited for it to become clinically positive. Warning number 5, watch the lymph nodes. Consider sentinel lymph node biopsy for any conjunctival malignancy. I only have a single word to say about conjunctival metastasis. They are rare, but be on the lookout. This patient came in with multifocal uveal melanoma metastasis from skin, and we flipped his lids and found conjunctival metastasis. And lastly, the simulating lesions. Beware the patient with a deep pigmented lesion in the conjunctiva under Tenon's fascia. It's likely to be extrascleral extension from a uveal melanoma. So in the past few minutes, we've raced through a lot of pigmented conjunctival tumors. Remember the warnings. Asymmetric racial melanosis could be melanoma. Large multifocal PAM, watch out. Nevus in the fornix is likely PAM or melanoma. When you resect, keep it dry and evaluate the lymph nodes of patients with conj melanoma. Thank you.